السلام عليكم ورحمة الله وبركاته. This is the third part of rheumatoid arthritis lecture. I'm Professor Dr. Abdelazeim elhefny. In the first part, we finished the rheumatoid arthritis definition and pathogenesis. In the second part, we finished the clinical picture, the symptoms and signs for rheumatoid arthritis diagnosis. And in this part, we will focus on the investigations, how to select the proper investigations to diagnose a case of RA. These are the ILOs if you want to revise. Investigations. Investigations and monitoring of rheumatoid arthritis. To establish diagnosis, there must be full clinical criteria, rheumatoid factor and or anti-CCP antibodies. One of them or both are positive, but some cases, about 20% of cases, they are negative. Also, we will ask about ANA and hepatitis S antigen and hepatitis C antibody to exclude other causes. ESR and CRB usually are elevated when there is activity of arthritis. Ultrasound or MRI can detect early synovitis. To monitor disease activity and drug efficacy, we can use the visual analog scale, pain scale, early morning stiffness duration in minutes, joint tenderness and joint swelling, DAS score, DAS 28 score, we will show later, ESR and or CRB follow-up. When there is improvement, these levels are decreasing. When the patient are still in activity, the levels of ESR and C-reactive protein, which are the acute phase reactants, are still high. Ultrasound of the joints also can give us some hints about synovitis and activity of the affected joint. To monitor disease damage, plain X-ray to the joint, to the neck, to the chest can be done to detect any joint damage. Also, functional assessment. In some cases, we ask for ECG and echocardiography to exclude cardiovascular affection. To monitor drug safety, like disease-modifying anti-rheumatic drugs or non-steroidal anti-inflammatory drugs, we can order urine analysis, urea creatinine as markers for for renal affection, and also liver function tests. CBC can give us a clue for presence of anemia, for presence of leukocytosis, thrombocytosis as markers for activity, or leukopenia and thrombocytopenia in some cases with Felty syndrome. Serological markers for rheumatoid arthritis diagnosis. First, rheumatoid factor, which is sensitive and present in about 70 to 80% of cases. Also, anti-cyclic citrullinated peptide, which is more specific for diagnosis of RA, especially in early cases. We will focus on these factors later on. The acute phase reactants, while they are non-specific, but they aid in the diagnosis of activity of the cases. ESR and CRB titr, which are, while they are elevated, they can give us clues for diagnosing the activity of the case. Clinical use of rheumatoid factor. A negative rheumatoid factor in 20% of cases does not exclude diagnosis of RA. RA patients with high rheumatoid factor titer tend to have more severe disease. It is of prognostic value, but there is poor correlation with disease activity. So, no use to repeatedly measure the RF. Causes of positive rheumatoid factor, either in rheumatologic diseases, infections, or other conditions. The student should search and answer these items in the face-to-face session. Cyclic citrullinated peptide antibodies, anti-CCP, or anti-citrullinated protein antibody, which is ACPA. These are more recently discovered rheumatoid arthritis specific autoantibodies with sensitivity about 85%, similar to rheumatoid factor, but very high and good specificity reaches 96%. This test is valuable in confirming the diagnosis of early RA. Anti-CCP antibodies can predict the development of rheumatoid arthritis. High titer of anti-CCP are of prognostic factor for erosive disease. Synovial fluid analysis, when we aspirate rheumatoid joint, which is usually inflamed and swollen, with increased the accumulation of synovial fluid in abnormal amount, we will see there is decreased protein, decreased glucose, decreased complement. Apparently, it is cloudy in color with increased white blood cell count. X-rays of the hand and other joints. Usually, we ask for X-ray of posterior anterior view of both hands, and it changes with progression of the disease. First, there will be periarticular osteoporosis, then loss of articular cartilage with joint space narrowing. The next phase, there will be erosions and or bone cysts, and finally there will be subluxation and. هنا برضك زي ما احنا شايفين this picture to the left shows soft tissue swelling and early erosions in acute phase or early phase of rheumatoid, and then periarticular osteoporosis and reduced joint space. And in his carpal bones, there is severe periarticular osteoporosis, bone cysts as shown here, and loss of demarcations between the carpal bones. Here, X-ray of the hands showing early rheumatoid arthritis, typical erosions at the thumb and middle metacarpophalangeal joints and at the ulnar styloid. On the left picture, on the right picture, there is subluxation and ankylosing of the intercarpal joints, and in the first metacarpophalangeal and interphalangeal joints of the thumb, and also in the index finger, there is a complete loss of joint space and ankylosing and subluxation of the second metacarpophalangeal joint, and here in the third proximal interphalangeal joint, and is also here and here bilaterally. Here, MRI in rheumatoid arthritis, it is of great interest and great advances by using the MRI in the small joints of the hands, because it is more sensitive to detect early bone erosions and soft tissue changes in early rheumatoid, and also by this ultrasound technique, because it shows higher sensitivity than the conventional X-ray for detection of bone erosions and soft tissue changes. Differential diagnosis, especially case with chronic polyarthritis. It may be inflammatory or non-inflammatory causes. The common inflammatory polyarthritis are in the top of the list: rheumatoid arthritis, systemic lupus erythematosus, spondyloarthritis, especially psoriatic arthritis, chronic hepatitis C infection-related arthritis, gouty arthritis, drug-induced lupus syndromes. Uncommon or rare cases of paraneoplastic polyarthritis, remitting seronegative symmetric polyarthritis with pitting edema, RS3PE, adult onset Still's disease, systemic autoimmune disease and vasculitis, Sjogren syndrome, viral infection other than hepatitis C, Webb's disease. But the non-inflammatory causes may be primary generalized osteoarthritis, which is somewhat common and can be misleading for patients with rheumatoid if we are not concentrating well, hemochromatosis, calcium pyrophosphate deposition disease. One of these differential diagnoses is adult onset Still's disease. We will focus on this disease because it has some importance. It is a rare systemic inflammatory disorder of unknown cause. It is similar to Still's disease in children, which is called systemic juvenile idiopathic arthritis. Clinical picture: the patient has intermittent fever, rash, and arthralgia, with or without splenomegaly, hepatomegaly, and lymphadenopathy. Investigations shows an acute phase response with high ESR CRP and markedly elevated serum ferritin. Tests for rheumatoid factor and ANA are negative. Treatment: most patients respond to corticosteroid. DMARDs may also be required as steroid sparing. Interleukin 1 inhibitor, which is anakinra, anti-TNF alpha therapy, and tocilizumab, which is interleukin 6 inhibitor, may be of help in patients with resistant disease. Now, to diagnose rheumatoid arthritis as early as possible and as easy as possible also, the ARA, American Rheumatology Association, put criteria for classification of RA in 1987. Uh, it was 7 items for diagnosis. The first is morning stiffness more than 1 hour, arthritis of 3 or more joint areas, hand arthritis, symmetrical arthritis and bilateral, subcutaneous nodules, positive rheumatoid factor, and radiological finding in hand or wrist in the form of periarticular osteopenia or erosions, and the presence of at least 4 criteria of these 7 for at least 6 weeks can diagnose rheumatoid arthritis. But it is obsolete now because to use these classification criteria, we always diagnose rheumatoid arthritis in the late stage, which is irreversible erosions and deformities. So there is a new classification criteria now in 2010 by the American College of Rheumatology and by the European League Against Rheumatism. The best advantage of this criteria is the ability to diagnose early rheumatoid arthritis before any. The target population of this new classification criteria, there are two requirements. The first, our patient with at least one joint of definite clinical synovitis, that's to say monoarthritis at least, with pain, tenderness, and swelling of one joint at least. Number two, synovitis is not better explained by another disease. It is not traumatic, it is not degenerative. So, if it is unclear still for our level, we have to ask the expert rheumatologist to be consulted. This is 2010 ACR EULAR classification criteria for rheumatoid arthritis. It is the latest classification we are using nowadays. It it is composed of 4 domains. The first domain related to joint distribution. It takes from 0 to 5 marks, and the serology from 0 to 3 marks, symptom duration from 0 to 1, and also acute phase reactance from 0 to 1. The total score from 10 to define the patient as having rheumatoid arthritis. The patient has to have from 6 and more points from these 10 points. The first domain related to the joint distribution. If the patient has one large joint arthritis, he will take 0. If he has from 2 to 10 large joint arthritis, he will take 1 point. If he has 1 to 3 small joint arthritis, he will take 2. From 4 to 10 small joint arthritis, you will take 3. More than 10 joints, either small or large, but at least one small joint arthritis, you will take 5 points. Serologically, if there is negative rheumatoid factor and negative ACPA, the patient will take 0. If he has low positive rheumatoid factor or low positive ACPA, he will take 2 points. If he has high positive rheumatoid factor or high positive ACPA, he will take 3 points. Low positive means that the patient has positive level but less than 3 folds. High positive means that the patient has positive test but from 3 and more folds from that of the upper level of normal. Symptom duration, if the patient is complaining of these symptoms for less than 6 weeks, he will take 0. If he is complaining of these symptoms from 6 weeks and more, he will take 1 point. Acute phase reactance, if the CRB and ESR are normal, will take 0. If any abnormal levels of the CRP or ESR, you will take 1. We do summation of all these domains and calculate the final score of each patient. As we said, if he took from 6 and more, he will defined as having rheumatoid arthritis. All these symptoms and signs, either prospectively over time, cumulatively, or retrospectively, can be added. Lastly, to sum up the essentials for diagnosis, rheumatoid arthritis usually has insidious onset with morning stiffness and pain in the affected joints, symmetric polyarthritis with predilection of small joints of the hand and feet, deformities common with progressive and chronic disease, radiographic findings like juxta-articular osteoporosis, joint erosions, and joint space narrowing may be observed. Rheumatoid factor and anti-CCP antibodies are present in 70 to 80% of patients. The extra-articular manifestations may be present in some cases, especially those with rheumatoid factor positive and with more severe disease like subcutaneous nodules, interstitial lung disease, pleural effusion, pericarditis, splenomegaly with leukopenia, especially in Felty syndrome and rheumatoid. This is the end of the third part of our rheumatoid arthritis lecture, and inshallah we will deliver the fourth part. And thank you.